Thank you. All right, everyone. My name is Rustin Taylor. I am here today. Dr. Wayne is leaving. I'll be giving the HIV lecture today. Dr. Wayne, did you want to leave me with a roster? Roster?
Yes.
Perfect.
Yeah.
I'll know
I'll
who
come
to
back
call on in class. Thank you.
at the end of the class and call your name.
Okay. So I want to start this off by telling each of you guys, who in here is like, I just want to get through the next test, I just want to get to the next thing? I see you shaking your head. So let me just, and you know what, I'm thinking about when I was in pharmacy school.
Yes.
The only thing that I was looking for is, when am I going to finish the next thing? When can I be to the next class? When can I be graduated? But let me tell you guys something. Once you graduate, you're done. And I haven't gotten in over 20 years to walk on a college campus. That's my own fault. I could probably go and walk on one if I wanted to. And yes, I've given lectures on one, but you're in a unique place. So you need to cherish every moment that you have, because when this is done, you're out. And then you'll be an old guy like me, and 20 years later, you'll be talking to a group of future pharmacists. So today what we're going to be talking about is human immunodeficiency virus. A little bit of history on me. I, for greater than 10 years, was a hospital pharmacist. Before that, I did my residency in pediatrics with an emphasis in infectious diseases. Today, I am at Legacy Community Health. Legacy Community Health is a federally qualified health center. And one of the things that we do there is we provide care for everyone, but especially to those who are underinsured. So we do have a very large HIV practice, and so I presume that is why I was asked to give the lecture today. At any time, if there are questions, please just let me know. You don't even need to raise your hand, just yell out. You will not cause me to lose track or anything like that. And I'm just gotta make sure that I know how all this works. I do not. So several things that we're going to be doing here. I'm going to introduce some basic principles of and history of HIV and AIDS. I'm going to identify antiretroviral therapies, classes, and also common adverse effects. To discuss preferred antiretroviral regimens recommended for those who are naive patients, meaning they haven't had any drug present before, those who are on pre-exposure prophylaxis, and also for post-exposure prophylaxis for HIV. And then last, we're going to review antimicrobial or antiretroviral stewardship and the role of the pharmacist and tools for checking drug interactions. So, I want to provide you guys with some resources, because one of the things we know is if you put anything about HIV into your search thing, the first thing that's going to come up is the branded drug that they want to sell that day. You're going to need to look down. This is where you can find the guidelines that you need to follow. These are set out by United States. They are peer-reviewed, and they are rapidly changing. So if you want to look at guidelines, this is the place to go. It will have everything separated into things that are easy to access. Also, the Centers for Disease and Prevention, this is also an area that has lots of HIV information. It also has pre-exposure and post-exposure. And the last one is a wonderful drug interaction checker. So I'll actually show you what this looks like at the end. All right, so let's get started. I love background. Some of you might be like, I don't care, that was 40 years ago. But at any rate, I was around, so that's how it goes. So one of the things that happened, and the reason why Legacy Community Health is here today is because in 1981, we were already around. And what Legacy Community Health was doing was basically treating sexually transmitted infections. But one of the things that was happening in the United States and in the world, really, was we had a new disease that was present. And on June 5th, 1981, the CDC published the MMWR. And one of the things that they were talking about were 5 previously healthy young men who now had an unknown diagnosis and they would quickly die. On the left, you have, this is a dermatologist, and this is someone from the CDC. So for these two to be paired up is real weird. So the reason why you have Dr. Conant here is because one of the things that he was seeing was Kaposi sarcoma on the skin of these normal, or they look normal, healthy young individuals. That should not be there. That should be something present in an 80-year-old, okay? And it should not be as aggressive as it was. So real weird stuff happened here. By September 4th, 1982, we finally got the term AIDS, which stands for Acquired Immunodeficiency Syndrome. Does anybody know what it was called before it was called AIDS?
GRID.
It was called GRID. Do you know what GRID stands for? Gay-related immunodeficiency. Is HIV a infectious disease that only impacts those that are gay, lesbian? No, it impacts everyone. So really important, and I think that's what the federal government missed and many in our communities missed, is if we don't take care of this, it's going to spread, and I'll show you what happens later. It took us, so we had no drugs until 1987. So, big deal here, we only had one drug in 1987, and in fact, it was adopudine. We still have it around today. The doses were so high that there were some people that were taking it that thought, I would rather die than take this. But this was the first time that we had one medication that in those who had HIV or advanced AIDS, we could prolong their life. One of the things that we quickly learned though was, can I use adopudine alone? No, I've got to have multiple drugs. So they were still learning this. And over the past 40 years, we've learned a lot. So today we have about 75 million people worldwide who are HIV positive. 32 million people have died of AIDS-related illnesses. So a lot going on there, and a lot that we'll be able to do today. So I'm going to tell you exactly what's going to be on the test. I encourage you not to tell those that aren't in this room what's going to be on the test, because I have on my little, I have it all printed out, and I have on my little deal. You better tell them about this. Okay, so I'm going to make sure that you guys know exactly what is going to be there. This will not be on the test. I think this is important from a historical perspective. So again, our first drug was in 1987. It was adopudine. This one, say it again.
That would have been nice to be on the test.
To be what?
The date and the subordinate would have been nice to be on the test.
No, nothing from this is going to be on the test. So just, yeah, no, I'm not putting dates on it. But this drug was honestly, one of the things for you guys to know is it was originally identified in 1964. And it was identified originally because they thought that it might be a cancer treating agent. So it got put on the shelf until 1987, and they figured out, hey, this might actually work. And we only had one drug. So we continue to get other, this is a nucleoside reverse transcriptase inhibitor. That's an NRTI. I'll define that a little later. We gained some other NRTI drugs. None of these continue to be around today. They were so toxic to patients. It was very hard for these drugs to be actually taken by patients. The year I graduated high school, 1996, was the first time that doctors started talking to patients saying, hey, you know what, guys, and everybody, you need to slow down because you're not going to die. Because this was the first time that we had protease inhibitors. This made a big difference for those living with HIV. So we continue to gain protease inhibitors. Notice that all of these are single drugs. So they would create a drug, it would be single, and then what you're going to start to see as we move years is we're going to have fixed dose combinations. One that I want before I change the slide to comment on here is we gained our first integrase inhibitor in 2007. So really big deal there. So we had a bunch, actually I'm going to go back one. We had a bunch of drugs that were singles, and then on the next slide you're going to see that they start combining these drugs. So whenever you're looking at this and you see FDC, that's a fixed dose combination, which means that they're starting to combine medications. So what we had before, single tablets, we started to try to combine those, then in the end, one of the things that I'm sure you guys are aware of today is we have a long-acting injectable that we can use to treat HIV, and we also have a long-acting injectable that we can use for PrEP. So that's where we are today. We've got lots of drugs. What the most important thing is, as we're talking about medications, is will the patient take it? If they won't take the drug, it makes no difference. Don't ever forget that. It's real important to learn. All right, so now we're going to go back to the basics. So HIV stands for human immunodeficiency virus. It is a retrovirus. I might underline that. This comes in several different flavors. One is HIV-1. So this is the predominant HIV strain that we have in the United States. There is also HIV-2. It is not predominant in the United States. One of the things to know about this is certain drugs that we'll use for HIV-1 will not work for HIV-2. we're not going to say any more about HIV-2 as HIV-1 is what predominates the United States. So HIV-2 would be a greater number of patients potentially in areas of Africa and different things like that. So once a patient then starts to lose their CD4 cells, then the patient will move to AIDS at some point. That stands for acquired immunodeficiency syndrome. This is the most advanced stage of HIV. So antiretroviral therapy is, we need to use it whenever we have it available, and that'll be on the next slides. It is recommended for everyone who has HIV. Today, if at Legacy Community Health you come in and you test positive, we are going to start you today on medication. We have gotten that good, and our medications are that non-toxic that I can get you started today. One of the things to know is we cannot cure HIV today. Now, yes, you could say I could get a bone marrow transplant. No, you're not going to want to get a bone marrow transplant. You would want to treat HIV rather than do that, because I do know that that has happened in 2 cases. Helps people with HIV live healthier lives. So one of the things to take into consideration is even if we're not going to treat HIV, one of the things that happens in addition to HIV is night sweats, weight loss, everything happens to your body. You can have scarring to your lymph tissue, diarrhea. This is something that you really want to get, and stay treated. It also, if a patient is on antiretroviral therapy for a good amount of time, one of the things that it can do is reduce the amount of transmission. So we can do this by getting folks that are HIV negative on PrEP, so we'll talk about that a little later. We can get those who have had an exposure potentially to HIV on post-exposure prophylaxis. But one thing I don't want you to forget is those that are on HIV treatment, if they bring their viral load down very, very low, there's no chance that they can give that infection to someone else. Okay, and we'll talk about that in one slide. All right, so this is an important slide. I would know exactly how HIV can be transmitted and in those that it can, ways that it cannot be transmitted. So HIV can be transmitted through direct contact with HIV-infected bodily fluids. This would be through sexual contact, it could be through IV or parenteral drug use, and it could also be perinatal, meaning mother to child, okay? Those are the ways that you can contract HIV. Ways that HIV is not transmitted, I would know this, is through air or water, saliva, tears, sweat, closed mouth kissing. Why would open mouth kissing potentially not be the deal? Why? I think a reason? Okay. You could have a cut in your mouth. So some patients could have ulcers. They could actually, and if the other one has an ulcer or some part of their mucous membrane that's disrupted, then they could share the infection. So that's what's important there, okay? Saliva in and of itself wouldn't be able to. Insects or pets, and then sharing toilets, food, or drinks. So one of the reason why this is so important is people don't understand this today still. And there's lots of stigma associated with HIV. So you have HIV, but the deal is there's not a whole lot of ways to transmit HIV unless we're talking about this. So real important to know that. So I would know this slide, and on the previous slide, I would know about antiretroviral therapy use. I'm circling the part that you need to know, right up here on the thing. You see, everybody get that? Okay. All right. So we're going to talk about immunosuppression now. So it's important for all patients with HIV to be routinely monitored. Every patient with HIV is going to have these tests run between every 3 to 6 months. The 2 most important blood tests that are there would include the CD4 count. We'll talk about what that means, and also the viral load. So here's a CD4 cell. It's an important cell to the immune system. Our immune system protects against all infections and illnesses. And the CD4 cells tell our body, hey, there's something here that shouldn't be here. And so one of the things that happens is if HIV impacts this cell, then you don't have enough to tell your body, hey, we've got an infection here that we need to deal with, okay? So a person with HIV is considered to progress to AIDS when either their CD4 cell count is less than 200 or they have developed one or more opportunistic infections regardless of their CD4 count. So it could be, they could have a fungal infection between their toes, it could be in their mouth. That is an opportunistic infection. And if someone, regardless of their CD4 count, has that, then they are considered to have AIDS. So let's go through this a little bit more closely, because one of the things that I just talked about is viral load. So in a patient that's HIV negative, there would be no virus there. Okay, very important to know that. But one of the things that happens over time is this HIV will start to incorporate itself into the CD4 cell. And then what happens is these will start to die. So when untreated HIV replicates and the viral load in the body increases, so one of the things to note, go ahead. It does, and I skipped over it. I'll go back. Thank you for bringing that to my attention. One of the things to note is the higher the viral load, the greater chance through sexual or IV contact that someone could acquire disease. Okay? So I've just got more disease there present, and so what happens is that we need to get that viral load as low as possible so that we can decrease the chances of sharing these infections. If ART is taken as prescribed, then viral suppression occurs. And what then happens is either the immune system rebuilds itself or it maintains itself to prevent illness. One of the things that we want to do in order to turn this viral suppression is to have the viral load less than 200 copies. That's important to you. 200 copies is important. That is viral suppression of HIV. Okay? And one of the things that we know is undetectable viral loads, and I'm going to go to the next slide because this is where it's actually stated. A person with HIV who takes HIV medications and he is either suppressed or undetectable. One of the things that the CDC says, and you will almost never see them say this, is there is effectively no risk of sexual transmitting of HIV. So you almost never see them say zero, and this is what they're saying here. And this is the U equals U campaign. Undetectable equals untransmittable. So now I'm going to go back several slides. Let's skip this one. One of the things that we see here is before HIV infection, so this is an HIV negative patient, we got lots of CD4 cells filling this little test tube. As HIV starts to replicate, one of the things that we see is the CD4 cell count goes down, the HIV viral load goes through the roof. So one of the things to know is in acute infection, the viral load is higher than it will ever be. And I'll show you on a graph here in just a second. Then the viral load will decrease, so you see the number of red decrease in here. You didn't see a whole big change in your CD4. CD4 cells decrease, and then there's almost none left. And this is the point at which you're at AIDS. Does that make sense? Mm-hmm. Yes? All right. All right, this slide is important to you. And what I want you to know is these names. So primary infection, acute HIV syndrome, clinical latency. So all of these things are important. This will be a multiple choice question. What you have on your axis here is CD4 count. So in someone who's uninfected, it would be very high. The red portion is HIV RNA viral load. So one of the things that you see is we have a very high CD4 count in those who are HIV negative. Then we have the introduction of HIV. You see that this spikes, and this is the highest that viral load will be. And so one of the things that I often get asked is, well, why do we want to start HIV therapy so fast? Well, if I can get that viral load down, then they have lower chances of sharing infection with others. So one thing to always remember about those who are newly infectious with HIV is their viral load is the highest right up front. Go ahead. Oh. So right up front. So acute HIV, one of the things that you would see, very high viral loads, somewhat decreased CD4 count. So it will decrease. And then what happens over time is we see that the viral load starts to decrease, and it kind of hums along. During this time, there's chronic inflammation in these patients. So I would write that down. One of the reasons why that's important is inflammation impacts every organ of our body. Our brain, kidneys, everything, heart. And so this happens over time. So if we can get this to treat it, then this will go to 0. And we won't have to worry about that, and then our CD4 cell count will start to go up. But if we don't treat it, it will continue to rise at the point where our immune system fails. We will have zero CD4 cells, and then what happens is ultimately the patient will die. Okay? Is that any questions?
So is the blue line? Oh, so is the blue line?
So the blue line is our CD4 cell count, very high to start. Our red line is our HIV viral load. The question on the test is going to be something like, in this phase of HIV, so in this phase of HIV, we see that the CD4 cell count is decreased somewhat, and the HIV viral load is increased a bunch during the acute HIV syndrome. Okay, that's what your question is going to look like for this. Okay. Any other questions about this? Still makes sense? Still, I want to clarify.
About the blue line.
The blue?
Yeah, I don't know that.
So what happens with the blue line is over time, so no infection present, very high CD4 count.
Is that still HIV related person? Or that's
So this is before it's ever even present, okay? So it's not even there. But once it starts to be there, it's gonna take between 0 and 3 weeks to actually present itself. Then what happens is as soon as you start to have viral particles there, it will start to impact the CD4 cell count and decreases it, but you've got so much there. That's what's happening.
And it's taking over just like that too thing. Okay.
Exactly.
Okay.
You got this. Go ahead. Sure. So one of the things that happens is you've got almost no cells that are present, so it will go very, very high.
Question.
Go ahead.
So does it necessarily cause chronic inflammation? You mentioned like the chronic inflammation. Can you explain again what is it?
Down here.
She said chronic
Okay. So what happens whenever we've got HIV that's present and it's not being treated? It's constantly replicating, sitting there replicating all day long. What happens is that replication results in inflammation all over the body. It impacts every organ of the body. And so what happens in these patients is they can have more heart disease, more kidney disease, liver disease. Every part of their body is impacted. And so one of the things that we're trying to do is to get patients on treatment as quick as possible so that that inflammation is minimized as much as possible.
Okay. So
Makes
if you
sense.
treat it fast, you won't have the chronic inflammation.
We are going to minimize it. There will still be some, but it would minimize it.
Oh.
Okay? So, does this make sense to everyone? Okay, good. So ultimately what happens is HIV depletes our CD4 cell count, and then what happens is the patients have opportunistic infections, and ultimately these patients will die. So really important to know that. We are going to move into antiretroviral therapy. One of the things to know about this is a medication, before we had long-acting injectables, that patients would take at least every day. So I'm not gonna ask the question, but let me just take myself. I don't take, as a 45-year-old, I don't take a medication every single day. So one of the things to take into consideration is this could be a patient that could be very, very young. They don't take anything else and have never taken anything else. Their adherence to these medications may be limited. Real important, and they may have many, many different reasons for why that is, why they have poor adherence. It could be due to housing, it could be due to stigma, it could be due to many different things. And so one of the things that goes along with HIV diagnosis is that they have to find a provider. There is a whole care team that goes around the patient, social workers, many different things there. But we need to get HIV treatment started as quickly as possible, and then what happens is the patient is in a circular motion. Every 3 to 6 months, they're gonna need to come into the provider. Every month or every 90 days, they'll need to get prescriptions filled, or they'll need to get their long-acting injectable. So one thing to remember, they need to take their medications every day if that is an oral medication. They need to see their healthcare providers regularly. That's usually every 3 to 6 months. Now, you're like, who gets 3 months and who gets 6 months? Because if it's a 6-month visit, I want that. So generally, when we're thinking about who gets 3-month visits, those are patients that we expect are gonna have more STIs, they potentially have worse adherence. We wanna have more check-ins with them. Where those patients that we're going to call back in 6 months are those who have a good track record of showing up for their visits, they got good adherence, they might be in a relationship, or we don't anticipate that they'll have a whole lot of sexually transmitted infections. So that is how we're going to separate patients. All right. So when should antiretroviral therapy be started? Immediately, most of the time. And then ART is recommended for all persons living with HIV, regardless of the CD4 cell count. So that is very different from when I graduated. We would almost let people die before we get this started. So we have a very different way of treating HIV today that's making a difference for the patients that we serve. What to consider? So we need to think about adherence to regimens. We also need to think about socioeconomic circumstances. We're going to go through some requirements of drugs that may not work for patients if they are homeless. So we'll have to think about this. This last statement on, or this last bullet on this slide is very important. So I'm going to ask you a question. I'm going to say something like, patient comes in, they're 54-year-old, and they've got some neurologic deficit. So you need to automatically think, hey, this patient could have some type of meningitic process going on. So if you've got a patient, can a patient that has opportunistic infections be started on therapy? The answer is yes. Many times if it's TB, what we will do is we will at least start the patient on 2 weeks of TB therapy, and then 2 weeks later we will start the patient on HIV treatment. If the patient has cryptococcal or tuberculosis meningitis, delay of therapy is something that is warranted. So let me explain to you. When we were back on our slide here, we were looking at this. So one of the things I showed you is we got a fairly high viral load here, and we've got our CD4 cells decreasing. One of the things that we see happen in these patients is if they're here, and many of them will be when they first come to me, what happens is they've got tuberculosis or they've got meningitis, but their immune system is not functioning, meaning it's not going to respond, or it's not going to see that as, oh, I need to go and I need to get this, the TB or meningitis. What happens is the body is just kind of sitting there like, I can't do anything. But what happens is, let's say I start therapy, the viral load starts to decrease. Our CD4 cell count starts to go up. Guess what happens? All of a sudden that CD4 cell is like, hey, you've got something, you need to deal with it. And it's gonna try to go and deal with it. And what happens is there is a fight within the body, and it's called immune reconstitution syndrome. This can be deadly for folks, so we really need to be careful. So that is why we are going to wait to initiate therapy. This happens very infrequently that we have to wait.
Is it because it tries to fight both the HIV and the tuberculosis?
So what is happening is, in this case, if I start both at the same time, it's actually going after the tuberculosis, and that causes and depresses the body so much. It's fighting against itself, basically, and that is what immune reconstitution syndrome means. Okay? All right, so our goals with antiretroviral therapy are, one, to have maximal and durable suppression of HIV virus. So yeah, we want that. I want to restore and preserve immunologic function whenever possible. I want to reduce HIV-associated morbidity and mortality, and then prevent HIV transmission whenever possible. So that means taking the people who are HIV negative and getting them on PrEP. So the next slide is going to go through the 7 different portions of the life cycle of HIV. I do not want for you guys to think that in 15 years that we're still only going to have 7 different stages or steps in HIV replication. Because I can tell you when I was in school, we only had about 4. So now it's 7, and by the time you guys are my age, it'll be 15. So we're going to go through each of these. I know that the information can be small here. Can you guys see it on the copies that you have?
Yes.
Because one of the things that's going to be important here is I am going to ask one question. It is going to be related to drug and also the area where it is going to work. So we're going to go through step 1 is binding. It's also called attachment. And this is when HIV attaches itself to the receptors on the CD4 cell surface. Drugs that will block this, this pathway are going to be our CCR5 antagonists, very rarely used, or our post-attachment inhibitors, very rarely used. If we very rarely use something, I'm not going to ask questions about it, okay? Great. So does that make sense? So it's first got to bind to this cell in order to then move to the next stage, which would be fusion. Fusion is when the HIV envelope, so that's the outside surface of the HIV, starts to fuse with the CD4 cell membrane. They join together, and this allows HIV to enter the CD4 cell. Okay? The drug that would be involved here would be fusion inhibitors, not used a whole bunch. Okay? Step 3 is going to be reverse transcription. This one is used a whole bunch. Okay? So what happens in this stage is inside the CD4 cell, HIV releases and uses reverse transcriptase, which is an HIV enzyme, to convert its genetic material. It takes HIV RNA into HIV DNA, okay? The conversion of the RNA to the DNA allows HIV to enter the cell nucleus and combine with genetic material. Drugs that are involved in this area would be non-nucleoside reverse transcriptase inhibitors and also nucleoside reverse transcriptase inhibitors. This is one you might want to know. Okay. Integration. So this is our next one. So remember I told you we didn't get an integrase inhibitor until 2007. Integrase inhibitors, real important. We use them a lot, okay? So the deal is, with integration, is inside the CD4 cell nucleus, HIV releases integrase, and again, this is an enzyme used to integrate viral DNA to DNA of the CD4 cell. So a drug involved would of course be the integrase inhibitor. Okay. And then replication. So replication is once the DNA is integrated into the CD4 cell, then what happens is it begins to use the CD4 cell's machinery in order to produce additional proteins. The protein chains are building blocks for more HIV. I would know this one. Okay. What happens next, so we've made all these proteins and things like this, is we have assembly. So you can make all the proteins in the world, but if it's not assembled and cleaved and packaged the way that it needs to, it's not infectious yet, okay? So what happens with assembly is we have new HIV proteins and RNA, they move to the surface of the cell and assemble into immature, non-infectious HIV. So the last step is going to be budding. So this is our newly formed, immature, non-infectious HIV. It pushes itself out of the host CD4 cell. The new HIV releases protease. This is a very important enzyme. Protease acts to break up the long proteins chains that form the immature virus. So the smaller HIV proteins combine to form mature infectious HIV. So one of the drugs I talked about that when I was in high school, that when I graduated, and this was the one that they said, hey guys, you're not gonna die if you take your medication, is our protease inhibitor. Very important drug class that we have today. Okay. Any questions about this? I think everything that you need is written on your slide. I would review especially replication and then also, what was the other one? Reverse transcriptase. All right, any questions about those so far?
3 and 5.
What was that?
Just 3 and 5.
3 and 5 I would know.
Okay.
All right, so we've already talked about several of these. I've listed about 6 different classes. I would argue that these pharmacokinetic enhancers are not a class in and of themselves. These are the ones that we're gonna go through. Because these are the most often used medications that we have. Okay, so I don't want you guys to freak out. I know you see all these acronyms and you're like, oh my God, what am I gonna do? You do not need to know all of these abbreviations. When I was first in pharmacy school, one of the things as I worked in a hospital, we still had written orders. And they said, no abbreviations, except if you're writing for HIV. And the reason for that is our guidelines actually have these abbreviations there. You are not responsible for these abbreviations. If I am asking about a drug, I will write the entire drug out. So I've given you the abbreviations, but they won't be on the test. All right, so we are going to go through this. Remember when you were in very basic, I don't remember what it would be, maybe biology, and you were thinking about how is our DNA, what is it made of? And we talked about A, C, T, and G, right? Okay, we've got analogs for these. It means it looks similar to, but it is not the same thing as guanosine, okay? So one of the things about our nucleoside reverse transcriptase inhibitors are NRTIs. That will be how folks will refer to them. It blocks reverse transcriptase and prevents HIV from replicating. So HIV uses this to convert RNA to DNA. So you might say, well, why do I need more than one drug? Why do I need more than one drug? Why can't I just use one? And I'm asking because we're talking about reverse transcriptase. This is an enzyme, right? Is it a very smart enzyme?
Yes.
Is it smart, meaning it doesn't make errors? No, it makes lots of errors. And that is why we get resistance, because one of the things that happens, if I only put one drug there, it's gonna do everything it can to get around that pathway. And it will do it by having errors, and the errors will then be the variants that will be there, and they will be resistant to these medications. Okay, so if you look here, we have all of our base pairs that we would use to make DNA. So with this, abacavir is one of the first ones, which is guanosine. You do not need to know how many times a day you would take it or doses. Just know it fits into the analog group. Then we have the cytidines. These are important. Emtricitabine is one that is still around today. This is part of Descovy or Truvada, okay? The other one is lamivudine. One of the things, and this will not be on the test, I want for you guys to remember, emtricitabine and lamivudine, I could almost use interchangeably, okay? So I would not ever, I don't like using ever because then you're gonna be like, oh, well, that one time. I would not ever have a patient on emtricitabine and lamivudine because they're basically the same thing. They're gonna give you the same result, okay? Then we're gonna move down to adenosine. We have tenofovir. These are both the same, and I'm gonna explain the difference between them. It's just a difference in base pair here, okay? And then the last one is thymidine. So this was actually the first drug that we had available, zidovudine. So these are our nucleoside reverse transcriptase inhibitors, okay? Again, I will ask you what fits into what category, but I will not ask you drug dose or frequency. Okay, don't freak out about this slide, no problem. One thing I do want to point out here is there are what we call 2 HIV backbones. 2 HIV backbones. I want you to look at, and we're just going to use this 2 NRTI only combinations. We have tenofovir and we have emtricitabine, okay? We have tenofovir and emtricitabine. We have other things. Tenofovir, emtricitabine. One of our backbones for therapy is going to be tenofovir and emtricitabine, okay? Patients will be started on that. Patients could also, although this happens very infrequently, you notice down here where we have things like Synthilo, you see this right here? Mm-hmm. They got real smart and they said, you know what? This efavirenz, emtricitabine, and tenofovir I can't make because they've already got a patent on it. But you know what I can do is I can switch that emtricitabine over to lamivudine and I've got a patent of my own, and that's what they did, okay? So that is really not a backbone that we use all that often, tenofovir and lamivudine, but we could, okay? The other backbone that I need you guys to know about that is very common is abacavir lamivudine, okay? So when I talk about HIV backbones, what I'm talking about is either tenofovir and emtricitabine, or abacavir and lamivudine. Does that make sense?
One more time.
As we look at this chart, the 2 backbones that you're going to see here are going to be abacavir and lamivudine, and tenofovir and emtricitabine. Okay? So as you start to look at a regimen, those are 2 drugs. Generally, when we're thinking about an HIV regimen, how many drugs do we generally need? 3. So there are regimens today where we can get away with 2 drugs, and I'm going to show you that here in just a slide. But generally 3, okay? So several things to take into consideration, and I would definitely know everything on these, about these nucleoside reverse transcriptase inhibitors, because one of the things I will do is I will ask you about a specific drug and then things that go along with it as far as side effects. One thing to note that you can see with all of these drugs, especially up front, is these patients could experience nausea vomiting. I generally term this a startup syndrome. So for the first week or so, patients could have nausea, they could have some vomiting. They may also have increased gas and things like that. It generally will go away. Patients, when you are educating them about taking the medication, try to get them to start by taking it with food. That will help. Several things I want to bring up. Abacavir, this is real important here. You do not start abacavir unless you have HLA-B5701 testing result back. Because guess what? If that patient, well, this is actually something that did happen. If patients are positive for HLA-B5701 and they take abacavir, basically all the skin on their body can fall off. They almost look like a burn victim. Wow. They will be in the ICU, okay? So this is not one to play with right here. So know that you've got to have this result back, and this is the reason why this will never be included in the rapid start protocols, because we don't have this result back, okay? There are other things that it's talking about here. Several years ago, there were many different studies that were talking about, does it have cardiovascular risk associated with it? One said it did, another said it did, and the meta-analysis said, no, we don't think so. Not a whole lot there. But one of the things you're gonna see, abacavir is not used all that often. There are drugs where it's present, but again, not all that often. Intracidamine is one that we're gonna use a whole lot. So if you look here, it's FTC, and if you look, is lamivudine on there? No, lamivudine would be 3TC. So I'm telling you, these are very similar drugs, okay? One of the things about this is it can cause skin hyperpigmentation. Not very often, but I have seen it before. Zidogudine. This one is actually really, really cool. Because back in the day, one of the things that I would always look for to see, is this patient taking their medicine the way that they would, is we would draw labs. All of these patients, if they were taking it the way that they should, would be neutropenic. 100% of the time, if they were taking their medication, I could tell they were neutropenic, and there was very little that I could do about it. They will also be anemic, but even if you give them iron, it's not going to make a difference for them, okay? They could have diabetes, mellitus, and they could also have insulin resistance. So this sounds like a really dirty drug. One of the things I want to share with you guys is, very early on, patients didn't want to take it because the dose was so very high that it would give them explosive diarrhea. You tell me, you're walking around campus, do you want explosive diarrhea? No, they would stop doing this. And so what they eventually did is they cut the dose down so low that we still do use this medication today. Okay, so we just don't use it at the high dose that we used to. Okay? One of the things that we can see with these medications is dyslipidemia. So one of the things to know is patients with HIV today, it's a chronic disease, meaning I can treat you for the rest of your life, you can live normal, healthy, but one of the things is we're gonna have issues as far as your metabolic profile goes. So zidogudine is greater than abacavir, but we will see increases in triglycerides and also increases in LDL, okay? Now the last bullet here is real important. Anybody that's watched a Biktarvy commercial or a Truvada commercial or a Descovy commercial, all of you have seen this black box warning about the chances of hepatitis B exacerbations. Okay, so I just want to close this real quick. So the deal here is you can, when you're treating hepatitis B, you need two drugs. One of them is either going to be one of these, 3TC or FTC, and the other one is either going to be one of the tenofivirs. Okay, so I can actively treat hepatitis B with Truvada or Descovy. I can treat it. But one of the things that happens is, let's say that patient changes their mind, they're like, you know what, I don't want to be on PrEP anymore. I'm not taking that Biktarvy anymore for whatever reason. What happens is hepatitis B will flare, and when it flares, patients can die. So that's why you have a black box warning. So you have to keep two drugs on. So it's either 3TC or FTC, and one of the tenofivirs, okay? All right, so let's talk about the difference between these. One of the things that, when you guys get out, you're gonna see this. As we get new drugs to the HIV arena, so we just got long-acting injectable product. One of the things that you're gonna see is everybody wants to go to that new thing. Problem is, when we start to test out that new thing on a lot of folks, we start to see, and we have problems, right? Okay, so let me explain this. This first drug right here, tenofovir disoproxil fumarate, TDF, is a portion of Truvada. Okay? The other one is tenofovir alafenamide, TAF. This is a portion of Descovy. What happens here is both of these are prodrugs, meaning we give it, it goes into the stomach. What happens in the plasma for tenofovir disoproxil fumarate is this gets broken down in the plasma to TFV. Okay? Now this can be active, okay? One of the things that this impacts is it's all around the plasma. The plasma is going throughout the body, meaning it's touching the heart, the kidneys, the bones, everywhere, okay? Where the other drug, TAF, stays as a prodrug in the plasma, and it's not until it reaches the lymphoid cell that it gets transformed into an active drug. So what that then results in is there's a 91% lower plasma tenofovir concentration with Descovy rather than Truvada, okay? So everybody wanted to go to this one. And you know, if I say that this one is a little easier on your bones, it's a little easier on your kidneys, everybody is gonna run to it, right? So what we found is it's a little easier on your bone and kidneys. If I stop it though, any one of them, everything will return to normal. But one of the problems that we have if we use TAF is, let's say that patient had underlying metabolic issues like triglycerides or LDL that are through the roof. If they're on this TDF, it will mask that, meaning it looks like their lipids are lower. Where when you put them on TAF, it will go through the roof, okay? So really important, because one of the things that we saw with this is everybody switched to the new drug, and then they're like, hold on. And so they would switch back. One of the things that we also see with TAF is there is about a 2 to 4 kilo weight gain, where there is not that with TDF. 2 to 4 kilos is a lot of weight, okay? That's 8 to 10 pounds, or 16 pounds, that's a lot. So real important to take into consideration, if patients are gaining weight, then we have issues. So I'm gonna move from our RTIs over to our non-nucleoside reverse transcriptase inhibitors. Are there any questions before I move on?
So which one is better from the previous? Are you saying that?
I am not saying that either one of them is better. What I'm saying is there are stark differences. If I need to use one or the other, I'm gonna look at the patient and see what's their insurance coverage. Do they have a family history of renal insufficiency or fractures or things like that. I'm also gonna look at their age. At 25 years of age, I'm not gonna break a bone. At 75 years of age, I might. So real important that we stratify based on what is most appropriate for that patient.
You said that TDF masks high triglyceride levels?
It can.
Okay, so wouldn't that mean that it's worse to be on that than the TAF because you want to be able to see the triglycerides?
So it's not that you can't see it, it's that the level is lower. So it's not just masking, it is
It's
lower.
actually controlling.
So really important.
Okay.
Any other questions about NRTIs before we move on to NNRTIs? And don't worry, you're gonna get everything confused because you're like, NRTIs, NNRTIs, ooh. So at any rate, we're gonna go through this. This binds to and later alters reverse transcriptase. So it binds to a different site. HIV uses reverse transcriptase, again, remember to convert RNA to DNA. So we've got in this section lots of drugs, but these are not drugs that we use very often. And the reason for that, I'm gonna show you in a couple of slides, is this is not a first-line drug for a naive patient to start, okay? These are not to be generally used as first-line in naive patients. Okay, so I'm going to not go from I'm not gonna go in order here. I'm gonna go as we gain these drugs. So the first drug that we had in this group was efavirenz. Sustiva, it's right here, efavirenz. One of the things to know about this drug is it was the gold standard that we used for HIV for a number of years until we got the integrase inhibitors. So if you ever look at old trials in HIV, you will always see we will compare everything to efavirenz. So historically, it was part of our first treatment regimen. One of the things, and we'll go on to this in the next slide, got lots of neuropsychiatric things that can be associated with it, especially if the patients take it with food. It has increased absorption, goes right to the brain and causes psychiatric issues. We'll talk about this on the next slide. Etravirine has issues, ropivirine has issues, we'll talk about this on the next slide. Nevirapine I very rarely use ever anymore. The new drug on the block is doravirine. So doravirine is Tyfeltro. It has a higher barrier to resistance, and it can be used once a day, and it has a lower incidence of psychiatric impacts. So I'm gonna go through this. So remember, they thought that they were really cute with the Symbi-Lo and whatnot, because what they did was they took tenofovir and they mixed it with lamivudine rather than intracidamine, and that gave us a different drug so that they could get a patent. This is ropivirine. Got lots of problems with that one. I told you with efavirenz, you need to take it on an empty stomach. Ropivirine, you need to take with a hamburger and french fries, because that is what is going to cause this drug to be absorbed optimally. Very high caloric intake. And then doravirine as a single tablet regimen is at the bottom. So, class effects associated with this, lymphohypertrophy. So one of the things that you can see is these people will be exquisitely skinny in their legs, but then you get to their middle part of the trunk and they have increased fat, especially with the fat containing products. So one of the other things that we can see with this is that it can be a rash. It's non-specific. And then efavirenz especially has a low barrier to resistance. So doravirine, as I said, is the next bullet item. This is a drug that we recently gained to our armamentarium. It's not first line. It is contraindicated with cytochrome 3A inhibitors. So some of those would be like carbamazepine, phenytoin, all of those types of drugs. And then weight gain. So we know that doravirine is a little bit more than efavirenz. But efavirenz was the big bad boy in the day. So one of the things that we saw with this is it would cause changes with triglycerides, LDL, HDL, and hepatic effects. So one thing to recognize is it's not recommended in hepatic insufficiency, and it can cause QTc prolongation. You will not see a whole lot of efavirenz used today, and that is because of the neuropsychiatric events. These patients, especially if they take it with food, can have suicidal ideation, can have depression, and sleep disorders. So one of the things I hear as we use this drug is I would always tell patients, you need to take this at night on an empty stomach. They'd be like, I never did that. And I'd be like, well, what happened whenever you did the other way? And they'd be like, my family always said I would get so angry and start cussing and fighting with it. It was because of efavirenz. So real important to know about that. Nevirapine, not often used anymore. This one caused especially severe hepatotoxicity. It also had skin rashes and hypersensitivity. We did have to use it for a number of years, but no longer, thankfully. Rilpivirine, real important, especially today, because one of the things that I've shared with you is we have a long-acting injectable. One of the portions of that long-acting injectable is rilpivirine, okay? Now with this, it can cause QTc prolongation. It doesn't happen all that much. It does inhibit serum creatinine without reducing GFR. So one of the things that you can see is it will bump their serum creatinine a little bit, but it does not impact their ability to excrete things freely, okay? And one of the major problems with this is it does require a high-fat meal, and we also should not co-administer with anticonvulsants or proton pump inhibitors, PPIs, okay? So real important that this drug is made so that we can inject it. If you know anything about this long-acting injectable, several months ago, maybe a year ago, whenever we gained it, it did require an oral lead-in. So you had to take pills to start. The problem is if I'm gonna take this and I need a high-fat meal, and I have a patient that is homeless, that may not be appropriate. So we have to think about those types of things. Because again, if the patient's not gonna absorb the drug and it has a low barrier to resistance, that may not be what we want to do. All right, any questions about our NNRTIs? Because we're gonna move on to protease inhibitors. Okay? NNRTI is not often used today. Our protease inhibitors, again, very important drug historically, because this was the point at which they started to tell HIV patients, hey, you're not going to die, you need to start to take care of yourself and save some money because you're going to live. But it inhibits protease. This is an enzyme that's necessary for replication and inhibits the formation of these particles into ultimately their infectious portions. You do need to know our three protease inhibitors that are here. Atazanavir, darunavir is what we use most. All three of these are boosted, meaning that I have to add ritonavir to it. So historically, ritonavir we used as a protease inhibitor. It was horrible. You had to take huge doses, and there could be resistance associated with it. And it interacts with everything. And that is actually why we're using it, is we are using it to keep the protease, or the atazanavir or darunavir, around in the body. So that is why we're using ritonavir. The important thing here is we've got 2 stars next to each of these, is that anytime you give atazanavir, darunavir, or lopinavir, it needs to be co-administered with ritonavir. So look at the bottom there and you can see we need to administer the ritonavir at the same dosing frequency. So it's no longer used. It is a proton pump, or it is a protease inhibitor. It's no longer used for that, though. Any questions about that? I heard somebody move or say something. No? Okay. So only a few combinations here. A big deal here, though. So remember I told you about this ritonavir? You see how these two are kind of together? If I had a liquid of this, guess how much alcohol is in that liquid? About 40%. And the reason why we had to have so much alcohol in suspension was because we couldn't get those two to stay in suspension with one another. So ultimately, they created a new inhibitor, and it's called cobicistat. Okay? And at that point, we were able to mix cobicistat in the same tablet with the protease inhibitor. So this drug right here, the patient gets everything they need. They've got the ritonavir portion, they've got the protease inhibitor portion. Make sense? So they had to change the drug, make it more lipophilic or hydrophilic so they could have everything in one tablet. Okay? because nobody, well, you might want to take a 40% alcohol shot once, but it's not something you want to do a bunch. Okay, so common adverse events here. Now this one has dyslipidemia is a hallmark. Dyslipidemia is a hallmark. It can also cause GI intolerance, especially up front. That can look like diarrhea, nausea, vomiting. There can be drug-induced hepatitis, although we see that less often. Lymphohypertrophy, again, they can and will gain weight, especially in the central region. This is a substrate for CYP3A4. They do however, have very high barriers to resistance. Historically, we have used these drugs because they're more forgiving than other regimens, meaning patients could miss doses, but really important there. We do know that diarrhea incidence is higher in those on lopinavir. It decreases with darunavir and also atazanavir, but we have increased triglycerides with all of them. Atazanavir, not so much used all that much. It can cause jaundice and it can cause kidney stones to be present, so it usually takes a while for it to get there. We do have to separate from H2 blockers and also proton pump inhibitors. Darunavir is really our workhorse. That is, if we're going to use a protease inhibitor, this is the one. It does contain a sulfa moiety. It does have a very high barrier to resistance. Take this one with food. So if it's going to hurt someone's stomach, it's less often going to hurt it if they will take it with food. And then lopinavir, ritonavir, again, not often used anymore. And one of the things that we did find is increased risk of premature delivery. All right. Now we're going to talk about our integrase strand transfer inhibitor, our NSAIDs. Real important drugs. This is going to be, these are first line on our guidelines. So many times we will take our backbone and we will add an integrase inhibitor to it. And the first integrase inhibitor here that you see, bictegravir, that is the integrase portion of Biktarvy. Okay? And you guys have all seen the commercials for that one. That's everywhere. Cabotegravir, this is the oral formulation that they would use for oral lead-in, but we could also give it as a long-acting injectable. Dolutegravir, prior to bictegravir, was one of our highest utilized drugs. Elbapentravir, just get rid of that one. It's in several drugs as a combination. It's a real crappy integrase inhibitor, so that one we would not use alone. And the last one is raltegravir. So this is Icentrus, and there are two different dosing formulations with this. There's one where you do it twice a day, and then there's one that's once a day. It does have a lower barrier to resistance than either bictegravir, cabotegravir, or dolutegravir. All right, so these show our combination products. Again, this elbapentravir, real crappy integrase inhibitor, and that is the reason, and this is the only integrase inhibitor that we will combine with cobicistat, which is a booster. All right, so several common side effects associated with this: psychiatric events, and really what this can look like is some of these patients, they won't sleep. So especially if they take it in the morning, they won't sleep for days. So that can cause a lot of psychiatric issues if you have to sleep. So one of the things that I commonly try with this is to take these medications at night. Okay, because so it's backwards. I usually try to have them take it in the morning because if they take it at night, then they'll have insomnia for days and then they won't get any sleep. Okay, so take it in the morning, not at night. They do cause weight gain. So one of the things I can tell you with this one is when there's weight gain with integrase inhibitors, it can be huge. And I'm talking like 60 pounds. So we have to watch this really, really closely because one of the things we don't want to happen, and it has happened, is folks to stop taking their medicine because they're gaining so much weight. So again, a drug that patients won't take is of no use to you. We've got a lot of patients on Biktarvy and integrase inhibitors today, so watching psychiatric effects, taking it at the time in the morning rather than at night, and then also weight gain. Bictegravir is the next one. It has a very high generic barrier to resistance, so know that that's the case. This is the integrase inhibitor in Biktarvy. Next, we're going to move to dolutegravir. We can see hepatotoxicity in patients. One thing I do want to bring to your attention is several years ago there was a question about pregnancy and neural tube defects. This is still listed in many different places, and I left it in this lecture, but I want you to cross it out. If you go through papers or you're going through guidelines, one of the things that you'll see if they have not been updated is several years ago, 2018, 2019, there was from Botswana information that we had these infants being born and they had neural tube defects. So the United States went crazy and was like, no, if you even think that you could be pregnant, no dolutegravir. So we put this in all of our guidelines. One of the things that they did then is they followed up that study and they looked at patients who were pregnant and they had them on different regimens. Some contained dolutegravir and some didn't. And one of the things that they found was the rate of neural tube defect in that population was about the same. So today, I do not have issues using dolutegravir in patients who are pregnant or pregnant, okay? We're not going to talk about alpha-tegravir. We don't really use that one too much anymore. Raltegravir, we can have lymphohypertrophy, meaning that fat moves different places. And then with all of these, we do see inhibition of serum creatinine without reducing the GFR. So the serum creatinine will rise, but their GFR will stay about the same. So know that that can be the case with dolutegravir and bictegravir. So that means, let me give you an example. You're looking at your lab results. Then you start to take bictegravir, and you look at them again. So before, I might have had a serum creatinine like 0.9. Now, when I come into the doctor, it could be something like 1.1. But I'm not going to see a change in my GFR, okay? Make sense? All right, now these are a whole menagerie of potential drugs. And one of the things that I need for you to know is, for the test, because some of these will be on here, is just what fits in which group, okay? So with this, we have the CCR5 antagonist, Maraviroc. Now, you will hear about this drug, but it's not often, or it is used for HIV, but there are other indications that they're studying now. So one of the ways that you're going to hear about this is they're using this now as an experimental drug in those who have long COVID. I have no idea why it would work for that, but they're trying it. They have also tried it in patients that are status post having a stroke. I don't know exactly why it works there either, but it does. One of the things to know here is the patient has to be homozygous for CCR5, and it's a receptor that we have within our body, okay? Not everybody is has both of their alleles that are CCR5. Some are CXCR4. If patients have that, this drug will not work, okay? Not often used. Fusion inhibitors. So this was years ago. This was an injectable. They had to inject themselves twice a day. And it basically left like a golf ball size divot on there wherever they injected for the entire day. So can you imagine you'd have golf balls all over your leg? And these could be painful. But one of the things, it did work, but we don't often use it anymore. Now the last two drugs are ones that are really coming to us, and they're newer. So fostemsavir and these, Trogarzo, will generally be utilized together. Once you get to the point of needing these two, we call these patients heavily treatment experienced, meaning I don't have other things that I can use on them. So earlier, I brought up the fact that generally, we have 3 drugs when we're thinking about an HIV regimen. In patients that are highly treatment experienced, Ricovia and Trogarzo will be utilized together, and there will be 2 drugs if they're active, and that will be your treatment regimen, okay? So you need to know how it works and what fits with what. Ibalizumab or Trogarzo is an injectable monoclonal antibody. The patients will get this infused every 2 weeks. So a lot of work there, but many patients, this is the only way that they can do it. They cannot rely on themselves to take a daily tablet. They have to have something scheduled where they come in, someone places a line, gives them an infusion, and they leave the clinic every 2 weeks. Any questions about those?
And these are for patients at what was it?
Heavily treatment experienced. It means I've burned through almost every other drug that I have, and I don't have other drugs to potentially treat them.
Yes.
So I'm going to just talk about several adverse effects that can happen with this. With the T20 or Varibertide, one of the things I told you already are injection site reactions. These are like golf balls. And you do have to give yourself an injection twice a day. With fostemsavir, again, we're going to use this along with ibalizumab. We can see QTc prolongation. We don't see all that much, and we don't use it all that much. Ibalizumab, definitely diarrhea and renal effects. Maraviroc, we have to have a tropism test before we can start, because again, patients can have varying receptors there, and if it's not CCR5, you're out of luck. One thing that I have seen in patients with this drug is it can cause rash, and it can also cause these patients to run a fever for several hours a day. Not something that anybody wants to experience every day. So rash is something that can happen with all of these. We are going to talk about our pharmacokinetic boosters. So again, we have 2. The first one that we have is ritonavir. This was originally used as a protease inhibitor. Today it is not. It inhibits many different things. We are using this for its drug interactions. Does that make sense? This does have some activity against HIV, and anytime something has activity against an infectious disease, it can also cause resistance. Okay? So, that's different than cobicistat. Cobicistat interacts with a lot of stuff. I think we thought that it would interact with less than ritonavir. Doesn't end up coming out that way. One thing to know about this has no activity against HIV. It is only there to keep other drugs around like protease inhibitors. It does not have any HIV activity. Let me make sure I've got you guys up to date with everything that's going to be on the test. You guys think of what you have questions about. And we're going to move to our next slide. So with all of our boosters, dyslipidemia is something that we can see. With all of our drugs, basically, that's something that can happen. Cobicistat can cause false elevations in serum creatinine, but again, not resistance. It does inhibit cytochrome 3A4. Ritonavir, it can cause resistance to other protease inhibitors, potentially, because it does have activity against HIV. It, again, is an inhibitor of CYP3A4. It should be taken with food. So now we're going to get down to the point where we are going to create an HIV regimen. So we got many different things that we need to talk about here, but I'm going to tell you what really happens in practice. We got this long list of stuff, but in practice, I've got 2 drugs that I can use if I want to rapidly start somebody on medication. Okay, so we're going to go through this, and the 2 drugs that we're going to use generally meet these criteria. All right. So the first one is, what is the patient's pre-treatment viral load? So when they get started, it can be very high, 3 million. In some patients, there are some drugs that we can't use once the viral load goes above 500,000. So the drugs that we will use in these patients, especially for rapid start, Biktarvy, very high barrier to resistance. It doesn't matter what your viral load is to start. And also Centuza, which has a protease inhibitor in it. So for some drugs, we need to think about our viral load and CD4 counts, especially rilpivirine. Okay? We need to think about genotypic drug resistance testing. So again, we use Biktarvy and Centuza. One of the things we know is regardless of what that resistance test tells us, they have very, very high barriers to resistance, and even those that do show resistance parameters can still generally be treated with those drugs. We need to have an HLA-5701. I told you why, and that was with which drug? I see you. You got it. I see the name. Bacavir. And then we need to think about patients' individual preferences. There are some patients that are like, I want to take individual tablets and I need to do it multiple times a day. There are some patients, if you give me more than 1 tablet, I'm not going to be able to manage it. And there are others still that they're like, if you don't inject this in me, I'm probably not going to take it. We have to take all of those things into consideration. Anticipated adherence, again, very important. Comorbidities, do they have hepatitis B? If they do, if they have hepatitis B, that could impact the backbone that I'm going to select. If they don't have hepatitis B, I could potentially, if I have my HLA-5701, use a Bacavir, because I only have 1 drug, a Bacavir with lamivudine. I don't need to treat hepatitis B. Or if I have hepatitis B, then I need to use the other backbone. Does that make sense? Co-infection, again, with hepatitis B. And then we have to think about regimen-specific factors. And that could be barriers to resistance. It could be potential adverse effects. It could be known drug interactions. You have to think about what the patient's already on. Convenience, pill burden, dosing frequency, really important. Food requirement. That is something that's really important to the patients that I treat. If it's more than an apple or they need just a snack, that might work. But homeless folks, I don't have food on a routine basis to take my medication. So real important. And then last thing is going to be cost and patient access. So one of the things I want to, who in here, is there a program, is there a federal program or a state program where we can get HIV medications if a patient's uninsured?
I'm sure there is. Yes.
Wait, I heard something, but I don't know. Say it again?
I said I'm sure there is.
I'm sure there is. So yes, in all states in the United States, they have something called an AIDS Drug Assistance Program, or ADAP. So every state has one, we have one here too. They are going to look at a patient's federal poverty level, and then they will determine if a patient is eligible for the program or not. So what this looks like for my pharmacy is, every
If
day,
you're
I've got,
homeless, you still have to qualify?
what is that?
If you're homeless, you still have to qualify?
They have to go through a process, yes, everyone must. They have to be able to demonstrate all of these things. And yes, you're bringing up a definite barrier, because if someone's homeless, there's a good chance that they don't have many of the things that they would need, like a light or power bill, so they can prove that they live here. Lots of things going on. So it is hard to get in these programs, but let me bring back the fact. Why would we have a program through the state that would give get medication to people, but I don't have that for diabetes, hypertension, and everything else? Why? So you're bringing up, so I can't give diabetes to someone else that I have sex with.
Public health issue.
It is a public health issue, correct. And so that is one of the reasons why we have programs to assist those who don't have these medications. But one of the things I want for you guys as future pharmacists to know, you gotta do whatever it takes to get patients the medications that they need to take, okay? If it means getting a copay card, I know if you're working at CVS and Walgreens, you don't have time to do all of that. But you gotta make that time, because some of these patients are gonna show up to you, and they're gonna be like, I can't pay for this. And they need to have this medication. So be passionate about this. Real important. So again, one of the things about building a ART regimen for a patient that's naive is generally 3 different drugs from at least 2 different classes. We need to have 2 NRTIs. So this, you can also replace 2 NRTIs, but you have to have a backbone. Have to have a backbone generally. And the last thing is, to that, to the backbone, we will generally add an integrase inhibitor, a non-new, or a protease inhibitor. Okay? So this is what our current guidelines show. So if we continue to go through this, every single one of these contains an integrase inhibitor, bictegravir or dolutegravir, correct? And then as we go through here, you're going to see tenofovir and emtricitabine, one backbone, abacavir and lamivudine. Again, I cannot start this until I have what back? HLA 5701 testing. It cannot be started until I have that back. And then you brought up the 2-drug combination that is here. But if you look at it closely, it's going to have issues down here at the bottom. So except for individuals with an HIV RNA that's greater than 500,000, if they have hepatitis B co-infection, or when ART is to be started before the results of the genotypic testing would be available. Does that make sense? Okay. So one of the things that I did with this is, you have your 3-letter code. I didn't want anybody to be upset about that. I gave you brand names and generic names, okay? So you're covered. All right. Any questions about HIV? Because we are leaving that room. Questions? Because I have time. I think I was given 2 hours on this. And you do need to know the chart that was before here. You at least need to be able to recognize what would fit into a treatment-naive patient. Go again?
We got you.
Okay. So I have a great question from the front, and I want to bring this to all of you because it's something that's very important. When we were talking about 40 years ago, so today, those individuals from 40 years ago, 30, 40 years ago, are older, right? So one of the things that has been tried in Houston is to pair older HIV positive individuals with younger HIV positive individuals. How do you think that worked out? When I paired them together so that we could work on drug and medication adherence and, you know, taking your medication and the importance of it. How do you think it worked out for me?
Well,
Back
if
in
you
my
compare him
days.
with this generation, it's not gonna work out.
It was terrible, and you're right, and that is exactly what happened. So one of the things to know is, and you're bringing up something real important here, when patients were dying in droves, everybody was scared to death to get HIV. Today, I've got good treatment, I got PrEP, I'm not worried with it. And so what happens then is there's a less emphasis on all the safe things that we could potentially do. And so that's why I want to bring up PrEP and also post-exposure prophylaxis here, okay? Because today, one of the things that we see is, you know, protecting ourselves is not as important as it potentially once was. So PrEP for HIV, so pre-exposure prophylaxis, it has the potential to reduce HIV transmission rates by sex by up to 99%. 99%. Now, you guys have seen commercials. You know that 99% is not always put out there. Why? Especially in women. I could have rates of success as low as 20%. Why?
Money.
It could be money, but patients don't take the drug. So this has been shown time and time again, even in investigational trials where there was no money involved. There are many times where patients just don't take the drug. So I do want to talk about this approved oral PrEP medications, and I put this in red because now we have a long-acting injectable. And I'm going to get you to write something that will be on your test associated with Truvada and Descovy. Get ready, okay? This has to do with the FDA indication. FDA indications are important to you, and let me explain why. If I have an insured patient and I put medication through, and I say that medication is only approved for diabetes, but this patient doesn't have diabetes, and then it's only weight loss, insurance is not going to pay for it, right?
Right.
Okay. Truvada was the first drug that we obtained. About 2012 we got this drug. This drug, at first, was only FDA approved in those born male. The reason it was only approved in those patients was because the tests or the studies in women were coming out with horrible results, and they thought, does PrEP just not work in women? The answer to that is no, it works in both. But one of the things, if you look down here at the bottom, is it takes up to 21 days of a dose-born female in order to get adequate levels of the medication into the cervical area, okay? It takes that long. So if you miss a day, your concentration is lower than it should be, and you have the chance of acquiring HIV. For those who are anal sex, then they only need 7 days in order to achieve protection. Today, we have adequate studies with Truvada, so that it is FDA approved today for use in those born both male and female. Okay? Descovy is a different story. This is only available to those who were born male. Okay? And the reason is because there has not been a study to date in females. Now, we will use Descovy for HIV treatment in females, but we will not use it for PrEP in females. Okay? Not that I don't think it would work. I think it would work. It has not been studied. Okay? Real important. So Truvada, male or female. Descovy, male only. Okay? Counseling points associated with this. Patients can routinely see, especially up front, diarrhea, nausea, headache, fatigue. They could also have increase in gas. This goes away over time. Usually it takes about a week. Ask the patient to take it with food, and generally that will decrease any of these side effects. So PrEP reaches maximal protection from HIV. It's going to take, for receptive anal sex, it's going to take 7 days in order to reach the level it needs to. For receptive vaginal sex, it's going to take 21 days of daily use in order to reach that level. You will need to know that for the exam.
So is this the fill in the blank part?
So basically, it's going to say who is Truvada approved for, and then it's going to say how long is it going to take to reach the protective level. So it's going to be asking you who are these approved for. It's going to be asking you how long does it take to get to protective levels. So that's all I have on PrEP. Does anybody have any questions there? Oh, maybe I have one more, and it's actually about injectable PrEP. So this is an injectable. It was just approved this year. It is a single drug. So if I'm thinking about hepatitis B, would I use this medication? No, and I wouldn't use this medication because I need it. I need the tenofovir and intracidamine. So this is only an integrase inhibitor, so it would not treat hepatitis B. It has to be administered by a healthcare professional. So I, as a healthcare provider, can do that. And we do, in our pharmacy, administer, we probably have 300 to 500 patients on Apretude alone. So we'll give a 3 ml injection, and we'll give it either ventrogluteal. Patients did not like ventrogluteal administration. They said, you're giving it to me in my hip. This is how you would give a ventrogluteal injection. Versus dorsogluteal, which they understood because they've had penicillin shots before. So there are 2 different ways to give it. Ventrogluteal is one that they recommend or prefer because it has lower amount of fat that's there, where dorsogluteal has more fat there. but it is something that could be utilized. You don't need to know it.
So when do you, use this one with the oral lead?
I never use this with the oral lead. I don't have to have oral lead with this. And the reason is because cabotegravir has a very, very low rate of any type of reaction. So I could get this started in someone. It's long acting. We shouldn't have any issues. So there, you could use the oral lead, but I have not on any of these patients because it just keeps me, it's keeping me from getting them going another month.
Okay.
It is indicated in those born, children 12 years and older and adolescents, or those who are greater than 35 kilos. And this one has been studied in cisgender men. Okay, does everybody know what that means? I remember the first time I saw cisgender, I was like, oh, right, so one of the things that we're thinking about a double bond, it's cis is on the same side of the double bond, trans is on the other side, right? It's also in trans women, cis women, and all that are at risk of acquiring HIV. One of the things to know about this is when they compared this to Truvada, one of the things that the government required, FDA required of them, is that they demonstrate superiority. And that goes into the fact that when we're thinking about PrEP, we had such terrible results in women because of the amount of time it took to gain protection against it, that they wanted this to show superiority, not non-inferiority, because then remember those studies that had like 20%, this would be like 19, no, they wanted to see something better. And ultimately they showed that this injectable PrEP decreased the incidence of HIV by 69 to 90% more than PrEP. And that's just because once that drug is there, it's there. The people aren't having to take it each day. One thing I do want to point out about this is, and this is the same for the HIV medication that we're not talking about today, is you will always get a patient started today, so this is month 1. I'm going to see them back in 1 month for another injection. After the second injection, if they stay on time, then I'm going to see them every 2 months thereafter. Makes sense? So back to back for months 1 and 2, then every 2 months thereafter. All right, now we're going to move to post-exposure prophylaxis. Anybody have questions about PrEP before I move? Negative. So post-exposure prophylaxis. So this is, you've had some type of exposure, condom broke, whatever happened, and you're like, I've got to go and get some assistance here. So what happens is many of these individuals will report to an ER. The ER is going to give them a couple doses of HIV prevention medication, and they're going to send them out with a prescription. Guess what? How that works out for a patient that's not insured? How does it work out? It don't work out at all because they have no money. They can't pay $6,000 for those 2 medications, right? The other time, what about an insured patient? Is it always just slam dunk, I'm good?
No.
What could happen? Prior auth. Another one that is one where I'll get on the phone and yell is they require mail order. And let me just get to my next point to tell you why that's a big problem and why you as a pharmacist need to recognize that's a problem and I need to do something. And that means getting on the phone and talking with the insurance representative because you are initiating post-exposure prophylaxis and this patient had a total of 72 hours from exposure, okay? So if this happened on Sunday and they show up to me on Tuesday, I can go ahead and get them started. If this happened on Sunday and they show up to me on Thursday, should I start drug? No. No. So what happens if they showed up to the ER, they did what they needed to do, they got started on medication, they were given prescriptions, and then they couldn't fill them? I shouldn't do that either. So one of the things that happens most often is patients will show up on my doorstep when they've been to every other doorstep to try to get this filled. There have been 5 or 6 pharmacies, everybody getting the same result. Ultimately, they'll show up to us. So really important here, things that we'll commonly use will be Truvada. That is an FDA-approved indication for PEP. Descovy is not. Okay? Our counseling tips with this are going to be the same. Nausea, vomiting can be there. Take the medications with food. These regimens are taken for 28 days. Okay? And we have to locate pharmacies with medication supply. Does every pharmacy have Truvada and Tivicay in there? No. And so you've got to find the right pharmacy. So the deal is you've got 72 hours to get everything done. So real important here. So if you are the pharmacist and you go again.
You would already know those specialty pharmacies that have it, right?
I do know, yes, because one of the things is and you should too, one of the things that happens is if they show up to your pharmacy and you're like, I cannot do it, but the place that will do it is Legacy or this pharmacy or that, go there, they will help you. One of the things that we have available for our uninsured patients, these both have patient assistance programs associated with them. You can apply for that patient and you can get immediate access. Who works in a pharmacy here? How many times have you guys ever put through a patient assistance program application? Negative. You've never done that. Why? Why? It takes time. It takes time. You have to have signatures, all of this type of thing. It's not something that generally you'll do in a normal retail pharmacy. So again, get them to somewhere that will. One of the things that we do, we fill these out every day, all day, to make sure that we can get the folks what they need. Follow-up monitoring, really important, and we'll show this on a couple of slides. And then they have to really think about their partner. So if they have a partner that's not the same one that they had the exposure from, then they need to think about protective behaviors.
Truvada, yes,
Truvada, yes.
and Discovery, no.
Discovery, no. Is not FDA approved for post-exposure prophylaxis.
That's what they do.
Okay. So, the drugs that we're generally going to use, again, this gets like an old book. Tenofovir and intracidabine, those are the backbone. This is Truvada. And you can use either Raltegravir. I'm sorry, but Merck does not have a great patient assistance program, so I don't use that one very often. I almost always exclusively use Tivicate or Dolutegravir, that's through Viv, and they do have a fairly good and easy to use patient assistance program. There are other alternatives. I don't use these because many of them don't have patient assistance programs, but there are alternatives there. The key to this is the patient has to be HIV negative before I get this started. If the patient already has HIV, they will have HIV when we get done with that therapy, okay? So checking to make sure, does this patient have HIV is important. Because if they already have HIV, then I need to start therapy. And this could be therapy, right? Because I've got 1, 2, 3 drugs there. And that would be an active treatment regimen. But I want to term it exactly what it is, because for a patient that I need to give post-exposure prophylaxis to, I need to see them back in 28 days. I need to do more testing to figure out, do they have HIV or not? Again, somebody who's already HIV positive, after 28 days will still be HIV positive. We just need to know that. Does that make sense?
So, they don't have it here, but they've been exposed?
So that's what we have to find out once they show up. So if someone comes in and they say, I had an exposure, so it could be many different things. Then what the first thing that we're gonna do is we're gonna run a rapid HIV test. So we'll prick their finger, put it on, and we'll be able to tell, are they HIV positive or not? And if they're negative, then we will initiate this. If they're positive, then we need to go to treatment. Okay? But what I'm saying here is treatment and PEP are basically the same things. I could use this regimen and actively treat the patient.
But if they get tested down the line, is it possible they can still like get it because it takes time to show up?
Yes,
Okay.
it is possible. And that is why people for those 28 days are like basically, and they definitely could have nausea, vomiting, diarrhea, but they could have that outside of the drugs as well as their something else. So one of the things about this is there is non-occupational, so that's what we've been talking about, and then occupational post-exposure prophylaxis. What would be an example of a patient who had occupational post-exposure prophylaxis? So we haven't moved to that slide yet, but what would occupational be? A needle stick. So that would be like me giving an injection, I gave it, and then I pierced myself with the needle that I'd already given them. One of the things that happens in all of this, if this goes into your question, we start with HIV testing. Again, if the patient's positive or negative, that helps us we have a decision point there. Then we think about hepatitis B, because does the patient have hepatitis B, or does the one that we had the exposure with have hepatitis B, okay? Then we have to do sexually transmitted infection testing, because one of the things that we know, I haven't talked about it in this lecture, because I could talk basically about HIV and all the things that go along with it in about 2 weeks, is we have lots of sexually transmitted infections where it causes irritation, or it can cause blistering. And when we have irritation or blistering on the skin, what happens is then we have mucous membranes that are open, and we're able to share if there's any blood that's there. So one of the things to know is if the chances that you'll acquire HIV are higher if they have a sexually transmitted infection as well. Okay? And then there are other types of things, and we are going to obtain these at each time point. I need for you guys to know not exactly what you would do, but things that you would test for the test, okay? So HIV, hepatitis, sexually transmitted infections. All right, now we are moving over to occupational post-exposure. So again, this is like a needle stick. Happens in the healthcare setting often. If I was the healthcare provider, I would definitely get started on medication, even with low incidence rates for percutaneous exposure. So that is whenever I would prick myself, that's at 0.3%. And then mucous membrane exposure, potentially you were changing a wound dressing and you got into your open mucous membrane, some of their fluid. That's very low at 0.09%. But again, if I'm the person that had that exposure, then I want to get started on medication as quickly as possible. Now, one of the things with this is the medications that we will use in this instance are a little different. And it has to do with, we have a guideline for non-occupational and we have a guideline for occupational, and they are separate. So what is recommended in the non-occupational is different than what we have here. So generally that would be raltegravir plus Truvada. Now, think about this. If I was the one that was writing the prescription, and I'm like, you know what, I'm gonna just do what I did with the other one. Would an insurance company necessarily know what I was doing? No, because they think you might be treating HIV. They don't even know it's for post-exposure prophylaxis. So I have seen providers write for dolutegravir. It will work, it's just not something that is within these guidelines, okay? All right, and I gave you a thing where we're not doing anything with this. It's a whole bunch of stuff about occupational post-exposure and what we would be looking for. Again, we want to look, pharmacists are always looking for drug toxicities. You always need to look to see what else is this patient receiving, possible drug interactions, and then also adherence. Very, very important in these patients. But other than that, you won't be asked anything other than that. So now we're going to move into antiretroviral stewardship. So this should only make sense for you. This is a coordinated intervention that was designed to improve continuity of care for these patients that are receiving antiretroviral agents. It's really us looking and doing that reconciliation, dosing checks, mitigating any type of drug interaction that might be there, and then preventing viral resistance whenever possible. Now you do need to know what's in this checklist because that will be on there, and you may also have things about percentages. So medication errors generally are going to happen whenever folks show up to the hospital because you've got somebody writing for medications that probably does not know that patient. That patient may not be sharing their complete medical history. So real important. And one of the things that then results is you have, when patients are hospitalized, as high as an 86% chance of having some med error associated with that. Most hospitals do not have every single type of HIV regimen that's out there. They are very expensive and they're not all that often used. So one of the things that you may see is there may be common errors that could be drug omission. I mean, they didn't even write for it. It could be incorrect dosing or scheduling. So again, there are certain drugs where I would not mix it with a proton pump inhibitor or vitamins, or I need to take it with food. Drug interactions, we have to look at this because there are some where we could have significant drug interactions and it could result in resistance. You need to be able to tell me what is in our strategies that we might be able to overcome this. And several ways to do this using checklists. So with providers, you say, you start here, is it one of these? You need to use this step, so that would be a checklist. Another way to get things right is to have computerized provider order entry sets. So rather than them trying to search for Biktarvy or whatever else this patient may be treated with, it's got every drug that could be utilized there. And all they have to do is select it and it will do everything else for them. And then just reviews with providers. So I used to be the antimicrobial steward at Texas Children's Hospital. Every single day if there was an HIV patient there, the physician would always call and we would review everything on that patient's profile. So really important to know that that is another strategy by which we can decrease the chance of error. So what is your role? And I hope that in your future you become passionate about HIV care because it's one where we do have the potential to end the HIV epidemic. But we want to make sure that whenever we receive prescriptions that we get those prescriptions and medications initiated or restarted as soon as possible so that there are as few missed doses as possible. We want to look at what caused that patient compliance issue. What was the barrier there? Was it because they couldn't come pick it up because they didn't have a car? Was it because they're not enrolled in the ADAP program? What was the issue that kept them from being on their medication? Because this is what happens. If I have to enroll every 6 months in a program, there are some patients that every single time they were supposed to enroll at that 6-month period, they didn't do it. So that's a patient that I need to watch, because when they're here next time at 4 months, I want to get them set up so when 6 months comes around, I've already got them taken care of. So you're going to have to really do that. Review appropriateness of the antiretroviral regimen. Now, one of the things that came up is 2 or generally 3 drugs are there. I want for you guys to always look at regimens. If there's only 1 drug there, ask a question. It could be right. There are instances where a person might be only on one. I didn't talk about it today. But ask the question. Don't just, oh, that's what they did at home. No, no, no. You got to make sure that this is the right medication. It may require you to call the provider's office that provides HIV care. Refer to the most current guidelines. These are changing, being updated all the time. So what I look at today, if I look at it 2 months from now, will be different. So look that up. Don't print that stuff out and be like, oh, let me go and look at what I learned in pharmacy school. It's going to be different by the time we do it. Review the complete list of availability for dispensing. So just know what's there, and then evaluating drug interactions. That is very important, and it is an area where providers have very little experience or knowledge about what to do. All right, so speaking about drug interactions, you may have many different resources. One that I want to introduce you to is called the Liverpool Interaction Checker. This one's particularly good, and the reason why it's particularly good is, let's say when we gained Paxlovid for COVID, when we first gained that, they said, hey, there's a drug interaction. You need to think about adding more drug in there. About 2 weeks after that, they got additional data and they changed it. So this is always being updated. So what gets put in the first section is what HIV drug is it? And then what are we mixing it with? Okay? And as soon as you put in all the patient's medications, then what is going to happen is something like this. So a patient on cobicistat or rifampin, do not co-administer. So those are the type of recommendations that it's going to give you. And if you want more information about it, you can go down, you can select the hyperlink, and it's going to show you the data that's associated with that recommendation. So I'm going to close with this. Treatment of HIV is rapidly evolving. So now I told you just this year we gained a long-acting injectable for both PrEP and HIV treatment. We will gain one this year. I anticipate that is going to be an every 6-month treatment. So it's rapidly changing. So one of the things that is going to be necessary is we constantly need to look at our treatment guidelines. I gave you I think on the second slide that was presented here, the exact web link for the NIH guidelines. And then ART should be started as soon as possible after diagnosis. So again, today, one of the things that we do, we will prick the finger, we will obtain a rapid diagnostic. If that is positive, we will get the patient started on drug. And that's important for a number of reasons. One of the things that we want to do is we want to restore or maintain an immune system that's already there. So if I can keep it from being destroyed, I want to. Okay? Another thing is lots of these drugs can have side effects and they could interfere with compliance. So that's going to be something that we really need to talk to patients about. And then, as I say, most of our regimens are going to contain 3 drugs. There are instances where there will be 2. That's always a situation where I would check. We can have important roles to support these patients and make sure that we reduce the rate of errors, optimize transitions of care, and then review compliance, appropriateness of the regimen, and any drug interactions. I'm happy to take any questions. I do have more slides. I do want to acknowledge this presentation has been given, I think, for years and years and years. I know Jessica Babbitt, I know Ryan, I don't know Dr. Sue, but all of these folks have contributed to this lecture over the years. And then the last one, what questions do you guys have for me? The easiest way for this group to reach me is via email. I have never had someone write me an email to ask me something about the lecture, so I encourage you to ask questions. Never have I had someone write me, and I'm like, what is the deal? You know, what happened? So I had a whole thing of pictures of my family, but it's not here. And so one of the things I'm going to do is while you guys are coming up with questions, I am going to go on my Yahoo account, which I was ready to do whenever I got here because I didn't know.
I wanted you to flip through those papers, make sure we got it covered.
Oh, I did already. You got it.
Okay.
No, I did that. So I just want to show you this, but what questions do you have?